Alright guys, I am going to do your second and final review for musculoskeletal. Um, this review probably won't take as long as the one I just posted last night, but I definitely just did not want to mash everything into one video because it would have been like 2 hours long. So, as always, if you guys have any questions, feel free to let me know, leave your emails, and yeah. Okay, so first thing that we're going to talk about are musculoskeletal injuries. So these are like things like back pain, strains, sprains, all of that fun stuff. So musculoskeletal injuries account for 66% of all injuries, and they can be pretty simple and they can be really complex, just like anything else. Obviously, like as you increase in age, that increases your chances of having more complications and issues. These are very costly because they're so common. So, the first category of musculoskeletal injuries that I have is soft tissue injuries. So, this includes like strains, sprains, dislocations, and subluxations. So, soft tissue injuries. Things to remember about these are these involve your ligaments and your tendons. So, ligaments and tendons aren't like your muscle, and so they don't have good blood supply. And so, this is why these types of injuries can take a while. So, I'm sure like a lot of you guys have had maybe like a sprained ankle or something, and even though it's not broken, you might know how like it takes a while for this to heal, and that's because the ligaments and tendons just like they don't get that blood supply constantly like, a big chunk of muscle does. And so it can take a while. So, a strain and a sprain. So, this is abnormal stretching and twisting, and it's classified from first to third degree. You need to know the difference between a strain and a sprain. So, a strain is a muscle tendon injury. The way I remember that is because there's a T in strain, T in tendon, put them together. So, this would be like muscle, fascia, or tendon. And then sprain is a bone injury. So remember that ligaments connect bone to bone and then tendons connect bone to muscle. So sprain, that's going to be a ligament injury. Clinical manifestations of strains and sprains are like exactly the same. And like I said, if you guys have ever had one, then you know it's just basically really painful. You might have some swelling, definitely going to have decreased function, range of motion. You might even have a contusion, but definitely usually like self-limiting, and they're not going to like impact other areas. Treatment wise, we usually only do an x-ray for a diagnostic to rule out like a dislocation or to rule out a fracture. But the way that we're going to treat a strain or a sprain is we're going to do that acronym RICE. You definitely need to know RICE for your exam. I'm pretty sure we had to select all that apply. So R stands for rest, ICE is for I is for ice, and so that is because ice vasoconstricts, and so that helps to reduce pain. Um, what was I going to say? I just had a question when I was doing some practice questions about ice. I don't remember, but C is for compression, and so that would be maybe like an ACE bandage to limit swelling. One thing I have highlighted, which I feel like was on the exam, is you're going to wrap distally, and so that encourages fluid return. So you're going to wrap distal to proximal. E stands for elevation, and you usually do this for the first 24 to 48 hours above the heart to mobilize excess fluid and prevent edema. And patients that have strains and sprains can use any affected joint as long as it's protected by a splint or a cast. So that's also important to know. So that is strain and sprain. Like I said, I feel like it's pretty straightforward. Not too much to know. I would just understand the difference between the two and then also that RICE acronym. So then dislocation is the next soft tissue injury that we're going to talk about. So this is obviously a pretty severe injury, and it's usually of the ligament structures around the joint. So that's why it's considered a soft tissue injury. And it's a deformity in which there's a complete or partial displacement and separation of the articular surfaces. So one thing that's really important to know is that So a dislocation is a complete separation of the joint surface, whereas subluxation is just like a partial or incomplete dislocation. So clinical manifestations of a dislocation are once again pretty obvious, but pain, tender, swelling, and not being able to use the extremity are like the biggest things. And so diagnostic wise, we are going to do an x-ray because a dislocation is an emergency. Very important to know that. Because the thing is the longer that you have that dislocation, the longer that you could cut off blood flow to an area. So that's why it's an emergency. And so our nursing care is obviously, our goal is to realign that area because of the damage that can cause vascular structures. Avascular necrosis, compartment syndrome, repeated injury are also possible, like especially if you have like repeat dislocations. So that's why it's really important to take action fast. And so realignment is usually done like pretty quickly, and it can be done under sedation or like not sedation. So remember, subluxation is a partial, and then dislocation is a complete, and then remember those clinical manifestations and how a dislocation is an emergency because of the lack of blood flow that it could cause an area. The next category is sports-related injuries. So these are usually from repetitive movement with work or sport. So this would be things like your ligaments, so like your ACL, MCL, all of those fun things that we've probably all heard about. Cartilage, so like meniscus tears, rotator cuff injuries. Bursitis is inflammation of the bursa. That's usually in your knee. And so once again, nursing care is going to be pretty conservative. So like rest, heat and ice, NSAIDs. You might get a corticosteroid injection if it's happening like pretty routinely. So like when I did basketball, I had pretty chronic knee pain and I had to get a steroid injection in my knee. Not very fun. PT, rehab, all that fun stuff. One area that you should review that not only Dr. Schneider will probably test you on, but also like NCLEX wise, they love these questions for some reason, and that's on how to use crutches and canes. So remember, with crutches, we advance crutches with the weak leg, and then the strong leg comes forward, and the nurse is going to stand on the affected side. It's also important to remember that the weight should not be on the armpits, but should be on the hands. Yeah, that's right. And then canes. So canes, we're going to support on the good side, and we lead with the cane and the bad leg first, followed by the good leg. So very important to remember with canes that the cane moves with the bad leg. Whereas with crutches, crutches move with the weak leg, and then the strong leg comes forward. A lot of times these sports-related injuries are going to require surgery, but if not, like I said, we do that conservative treatment. Okay, so the next thing that I have is amputations. So amputations, a lot of times we see in military. We also see this in diabetes patients. Could be if like an infection gets really bad and you have to get rid of the limb. Typically upper limb amputations are more stressful than lower limb, but obviously like it depends on the patient. And then there's also BKA and AKA amputations. So AKA is above the knee, BKA is below the knee. So when it comes to amputations, there's lots of nursing interventions that we need to keep in mind, and you will definitely be tested on these. So first off, we want to prevent and detect any problems. So one thing I know we had a question on was what happens if there's like bleeding. So you should always have a tourniquet nearby with your amputation patients in case they just like that the surgical site just starts bleeding, and then you would change the dressing. Additionally, monitor for infection. So you guys all know your signs and symptoms of infection. Like I said, monitor that bleeding. And then this is really important. You'll probably have this on your exam as well. So you should keep a compression bandage on the area to reduce edema and shrink the stump into a good shape for the prosthesis, because we can't give patients with amputations prosthesis until the edema is all the way down. And so it's important to teach your patients that these compression bandages should be kept on except for bathing and PT. You should replace it multiple times a day and then wash and dry the bandages daily. Pain control, one thing with amputations is to keep in mind that phantom pain is very much real and we should still treat it. Therapy, we can use mirrors to train the body that limb is not there, and obviously psychosocial issues are a huge thing to watch out for in these patients. Potential complications of amputations, like I said, bleeding, hemorrhage, infection, phantom limb pain, psychosocial issues. However, this is what you need to know as well. I know we had a question on this. So you can have a flexion contracture. That's like the main complication of amputations and with the lower limb. And it's usually because your hip will be flexed or you sit in a chair for too long. And so basically what happens is these patients aren't changing position enough. And so because they don't have, like, they basically just kind of forget that they're in a certain position. And so if you keep that lower stump, if you keep it in the same position for a while, then you're going to develop a hip contracture. And so basically what you want them to do is you want to try and get them to change positions often, but also you want to keep in mind that they can sit in a chair and elevate the foot of the bed for the first 24 hours to decrease edema. However, after that, you don't want them sitting in a chair for more than an hour because you want them to be up and moving and changing positions. The biggest thing I have highlighted is that you want to encourage them to lay on their stomach 3 to 4 times a day for 30 minutes at a time with their hip in extension. And so that is also why a lot of times with amputation patients, and this is something that I've actually seen at work, is you don't have them put their stump on a pillow, because if it gets too high, then they're basically they're going to be in a flex position rather than an extended position. So I was actually in the room one time when I had the patient, literally it was as perfect as could be. The patient asked the nurse why he couldn't have pillows underneath his stump, and the nurse was like, well, we can't have your leg extended like this because then it's flexed and you're at risk for a hip contracture. So definitely understand that. So that is everything on amputations. So next is osteomyelitis. So osteomyelitis is a severe infection of bone marrow, and soft tissue. I have highlighted that staph is the most common cause. It's usually in the pelvis, tibia, or back, and adults with vascular issues from diabetes are at the greatest risk, along with those who have a UTI or a respiratory tract infection, because the infection can travel to the bone. So that's definitely the things I've highlighted. Other things, it can come from contamination of a compound fracture, or so that's when the bone is sticking out, or if you have repair, surgical repair, obviously an infection is a risk, or if you have indwelling hardware. It can be indirect or direct. So direct means that the infection enters from outside of the body, so that would be an open wound, whereas indirect is when the infection is carried into the bloodstream, so it's carried throughout the body. Obviously, we're going to do a bone scan, bone biopsy for a culture, MRI, things to rule out other conditions. As far as the signs and symptoms go, we break them into chronic and acute. So acute is very local and systemic symptoms. And so that's pain that's unrelieved with rest, pain that increases with activity, throbbing, constant. You might have malaise and nausea and vomiting, fever, increased heart rate, and then also edema around the area. Edema around the area, and then increased white blood cells for your labs, and then a high ESR. So I think I talked about ESR already, but basically that's how fast the red blood cells settle to the bottom of a tube of blood. So the faster that they drop, the higher the amount of inflammation. How fast rate? Yeah. So obviously like osteomyelitis, that's inflammation, infection, so it's going to be pretty high. Chronic osteomyelitis is present longer than a month and it fails to respond to the initial course of antibiotics, and local signs of infection are more common. So, like I said, with acute, you have local and systemic symptoms. So, remember, systemic is like all throughout the body away from the area of infection, whereas chronic is going to be more like at the site of infection. So, this would be like ulcerations, just like your local signs of infection that we know and love, constant pain, drainage, warmth at the site, that sort of thing. So obviously if you have acute, the first like way we're going to try to treat it is with antibiotics, but chronic, it's a little bit different. So talking about chronic osteomyelitis, so there's non-surgical management that we can do and there's surgical. So surgical would be like debridement, bone grafts, muscle flaps, or even amputation, whereas non-surgical is going to be very vigorous and very prolonged. So that's going to be like 4 to 6 weeks of IV antibiotics, followed by 2 to 3 months of oral antibiotics. So it's really important because there's lots of education that we have to teach our patients about this. So, for instance, this is very important. I would know this. Prolonged antibiotics can cause renal issues, GI upset like nausea and vomiting, suppresses your immune system. You could develop like super infections like C. diff, yeast infections. You might even have liver problems, photosensitivity, fluid retention. The list goes on and on. And so we want to teach our patients about the potential risk. We also want to make sure that they're set up with a home health nurse because if they go home on a PIC, we have to educate our patients on how to clean that and how to flush them. And then also, this is important, I know we had a question on this, if a patient has a history of IV drug use, we don't send them home with PICs. And so usually what's going to happen then is they're going to be in the hospital. And so I actually had a patient who was on our unit for like literally like 2 months because she had osteomyelitis of her C-spine. I think I've talked about her a couple times. Very interesting patient, but she had very, very extensive drug use in her past and pretty sure still current, and so they could not send her home on a PIC. Also, remember like drugs like penicillin, vancomycin, gentamicin, not gonna say that. So remember, we have to like draw our troughs with gentamicin and vancomycin. Also know that like tendon rupture is possible with Cipro and levofloxacin. Other things we can do that are non-surgical are hyperbaric oxygen therapy, wound vac. We want to immobilize and obviously treat the pain. Nursing management for osteomyelitis as a whole. So remember, we're going to educate the at-risk populations, so those that have vascular insufficiencies like diabetes, those that have orthoprosthetic devices because that is an infection risk. If they're immunocompromised, we want to educate them on pain relief, how to do sterile dressing changes, and how to we don't educate on that. We as nurses do that, the sterile dressing changes, because we want to be careful not to have any cross-contamination. We want to avoid contractures while they're on bed rest, teach them range of motion exercises, teach about those long-term effects of antibiotics and the signs and symptoms of osteomyelitis. And we also want to be splinted and have careful movement for these patients. So we want to avoid activities that increase circulation, so like increase production and heat, and we want to avoid constantly flexing if they're in bed. So that's everything on osteomyelitis. So then the next category of musculoskeletal injuries that I have is back pain. So back pain, super, super common. I'm sure almost all of us have had it. Risk factors, lots of things like pregnancy, repetitive lifting, stress, prior fractures, lack of muscle tone, poor posture, occupation, smoking, literally like the list is endless. Usually back pain is in the lumbar region, so your lumbar region is that last area of your spine because this area bears the most of our body weight and it's the most flexible spinal region. It also has a poor biomechanical structure, and it can be referred to this region due to like kidney or lower abdominal issues. And also, we can have nerve roots that are susceptible to injury because they follow a dermatome. So, acute low back pain, this is usually 4 weeks or less, and it's caused by undue stress to the back. So, clinical manifestations usually don't happen until after 24 hours of the injury or movement because it's a gradual increase in pressure. Treatment would be to rest, but you don't want to rest for days on end because that's just going to make you stiff. Treating the pain, so like NSAIDs and NARCs if we need muscle relaxants like Flexeril, massage, heat and cold, sleep in the bed with your knees flexed to take pressure off of your back, not sitting around all day, and then also teaching about prevention, so like losing weight, strengthening your back and abdominal muscles, avoid prone sleeping, and not smoking. Literally, I'm so screwed because I sleep on my stomach, but whatever. So chronic low back pain is more than 3 months, and this is because of repeated like episodes. And so causes for this would be muscle overuse, heavy lifting, abnormalities of the spine, obesity, lack of exercise, that sort of thing. Treatment wise, same sort of thing. We're going to teach how to like prevent it. It's like losing weight, smoking cessation, keep them moving, but also treating the pain. One thing I have highlighted here is how with NSAIDs, we want to limit Tylenol to 4 grams in 24 hours. I know we had a question on the exam. It was kind of tricky, and it was asking about back pain, and it was like, which of the following do you want to like teach your patients? I don't remember what the right answer was, but there was one thing about Tylenol, and I think it was like having your patients take like 2,000 milligrams of Tylenol Q4. And so, like, if you did the math, that would be way more than 4 grams in 24 hours. But if that's a question, just be careful for that and make sure that it's no more than 4 grams in 24 hours. And you also want to teach about how nephrotoxicity is possible with NSAIDs. So, like, they can damage your kidneys. So you should take them with food and watch for GI upset. Next thing I have is spinal stenosis. So this is a narrowing of the vertebral column or nerve root canals. Usually is due to like a degenerative disorder, so like as you age, but it could be traumatic or congenital. Causes, like I said, could be any of the above. So osteoarthritis of the spine, tumors, Paget's disease, trauma. So basically what I've highlighted here is that the compression of the spinal cord is going to cause pain that radiates to the butt and the leg, and that increases with walking and standing. And so how we treat this is a laminectomy, which is going to remove lamina in the spine to release the pressure on the cord. That is all I have on spinal stenosis. So then the next thing I have is degenerative disc disease. So this is also with the back, and this is how, as we age, your discs lose elasticity and flexibility, and so they cannot absorb shock as well, which is obviously an issue. So with this, we want to like teach our patients that progressive degeneration is a normal part of aging, and so we want to teach them how to like best care for their spine. The next thing and last thing I have relating to the spine is nursing care of a patient that had spinal surgery. As always, ABCs are always the priority, so like monitoring for those. We want to make sure that we're teaching patients that are taking narcotics, that respiratory status and constipation are like the priorities. We want to make sure the back is in proper alignment and look at orders for like the ordered activity level. A lot of times in my experience with having spine patients, like at least at Barnes, I would say most of the time spine patients don't get up the first day. Usually if you have like hip surgery or like a knee replacement, you get up within 4 hours. However, spine patients, it's a little bit different because the spine is more complicated and obviously more serious. So I'm trying to think. I feel like most of the time, like PT might come in and have a patient like sit up or maybe like stand on the first day, but a lot of times they don't get up until the second day. We also want to keep spinal precautions and teach them how to log roll. So this is very important. You cannot log roll on your own. I'm going to be honest with y'all, that's what I have written down, but like you very much can log roll somebody on your own. At least, I mean, I've done it before, but yeah, you very much can. However, like if it's their first time log rolling, I would definitely have another person in the room, or if they're a heavier, very like unsteady patient. But for the purpose of the exam, you should know that you cannot log roll on your own. And so basically how we do that is with our spine patients, we lower the bed flat, and then we have them roll over onto their side. They push up and basically like stand, or not stand, but they sit up in like one motion. We also want to make sure we have DVT prevention. Muscle relaxants are used like Flexeril, but that can cause constipation. Constipation is usually a huge issue for spine patients because they can't get out of bed very much, and also because of all the pain meds. Cerebral spinal fluid leakage is also possible after surgery, so you should immediately report a headache or if you see it on their dressing. We should also be doing a neuro assessment every 2 to 4 hours for the first 48 hours after a lumbar infusion. Other things we're assessing with our spinal patients are bowel and bladder function, incision, neurovascular, all those fun things. So we should look for redness, drainage, cerebral spinal fluid, neurosigns like weakness, and bladder and bowel issues. So that is everything on the back. So the last thing I have here for musculoskeletal injury is carpal tunnel. So carpal tunnel, I know this was a question. So carpal tunnel is a repetitive strain injury. That's strain with a T, in which there's edema or pressure from overuse of the hands and wrist and inflammation of the tendon that causes the medial nerve to be compressed. So know that carpal tunnel syndrome is a strain injury and it involves the medial nerve. It's usually exacerbated by hobbies and jobs that use the hands. So a lot of times we see this in like people that play an instrument or like checkers at a grocery store. This is also really important. I feel like we had to select all that applies on this because I know we had several questions on carpal tunnel. So you're going to have weakness on your thumb side. That's going to bring about clumsiness, burning pain, and numbness. As far as how we diagnose this, there's Tinel test and Phelan sign. So Tinel test is where we tap on that medial nerve and it'll cause tingling. And then Phelan's test is where we do this. So we flex our wrist dorsal to dorsal for 60 seconds and they should have tingling. You don't ever do more than that though, because it can cause damage. Collaborative care for carpal tunnel, usually you're going to have surgery if it's lasting longer than 6 months. But other things we're going to encourage our patients to do are to take frequent breaks at work, modify their ergonomics, change positions. We're going to teach them to splint at night. They might even get a corticosteroid injection. But basically, I know like that splint is a huge thing, and you might even notice like at the grocery store, checkers will oftentimes have like that splint on to help keep their wrist in like a neutral position. Okay, so that is everything that I have on musculoskeletal injuries. How much time are we at? Oh, perfect, 30 minutes. Okay, so the last thing that I have for musculoskeletal is, hold on, I need to get my notes figured out here. Okay, so osteoarthritis and rheumatoid arthritis, this is definitely a really important topic for the exam because there's lots of differences and similarities between the two. So in general, just to start off, so arthritis is joint inflammation, and so that can happen due to wear and tear, cartilage breakdown, autoimmune. whatever. One thing I've highlighted that is very important to teach with arthritis is that it's not a result of the aging process. Even though it tends to increase with age, it's not a normal process of aging, and it's also not confined to the elderly. Most people that have arthritis, it's usually chronic and can like really impact quality of life, but some people can also have acute arthritis and just like inflammation and like occasional flare-ups. So the first thing I'm going to talk about is osteoarthritis. So osteoarthritis is oh my goodness, let's try that again. Osteoarthritis is a degenerative disease that is not inflammatory and is not a normal part of aging. Very, very important to understand that. So as far as etiology goes, it's the most common form of joint disease in North America, and it usually impacts women over the age of 40, and it tends to develop really slowly over many years. One thing about this is it's usually asymmetrical, so it's only on one side of the body. And then it usually targets a few synovial joints. And so basically the patho behind this is that our cartilage isn't as elastic, so it gets damaged easily by injury or excessive use. The timing is impacted by a lot of different things, but long story short, as the cartilage breaks down, the bone is impacted, and so then you can actually form bone growths that are called spurs, and these can be seen on an x-ray and are like automatically an indication of osteoarthritis. Sometimes you can actually palpate these, and I've seen that, and it's kind of weird, not gonna lie. Bits of bone and cartilage may also float loosely in the joint space, so you could also see this on imaging. But as far as like diagnostic wise, we're going to do that imaging just to kind of like rule out other things and see if we can see spurs. And then also we might do an arthrocentesis, which is where we look at the synovial fluid around a joint. And if the white blood cell count is less than or more than 1,000, that suggests inflammatory osteoarthritis. So, as far as clinical manifestations go, the ones I have like bolded and highlighted is that it's firm swelling along the joint line, crepitus, which is that snap, crackle, pop like feeling, stiffness, limited range of motion, and then osteophytes, which are the extra bone growth that can impair nerves and cause pain. Your distal interphalangeal joint, I don't know why it says joints, but those are Herberdin's nodes, and then the proximal ones are Bouchard's nodes. So those can both be affected, but those are your distal interphalangeal joints and your proximal interphalangeal joints. One thing with osteoarthritis is that it's usually best in the morning, so the stiffness is less than 30 minutes, and then as you get up, get moving, the pain will get worse. It's also pretty cool when you feel the joint, and it's usually pretty enlarged. Like I said, you might hear that crepitus. The onset's usually pretty slow, and then it'll get worse over time. And there's no systemic signs. Very, very important, because that's one of the ways we distinguish it from RA. No systemic signs with osteoarthritis. As far as the sites go, so the deformity is specific to the joint involved. So usually it's in the hips, hands, knees, and the spine, and it's rarely in the wrist, elbows, or ankles unless there's like an injury. Very, very important to know that. Like I said, if it's in the hands, remember that Herberdin's nodes are distal, Bouchard's are proximal. And as far as osteoarthritis goes, our nursing interventions, so we want to control the pain and like help patients improve quality of life. We want to improve the joint function by exercising the muscles around the joints and helping patients to maintain a healthy weight, because each pound of excess weight that a joint bears is an additional 4 pounds per square inch on your joints, on your weight-bearing joints. Exercise can also help to increase cartilage in the knee joints, which would obviously help lessen the amount that is lost. And overall, we just want to help these patients to optimize their overall health and well-being. We can also use assistive devices, so like braces, splints, orthotics to help stabilize and support joints. Medication-wise, lots of different meds. So like Tylenol and NSAIDs are first line. I have that highlighted. And then tramadol is usually second line, and then opioids will be used if necessary after that. Corticosteroids can be injected into the joints. We can also do viscotherapy, which is where you like inject into the joint space this like lubrication that helps to cushion the joints. And we can also use topical pain relievers like salicylates and then topical NSAIDs. So like Voltaren is the most common one for that. And then we can also use nutritional supplements. It's not like backed by research, but patients like to take these and think they help. For surgery, we usually don't do this if you're under 50 or 60, but like if you're older, then you might get like a knee replacement or a hip replacement. And we can also use hot and cold treatment, relaxation, massage, that sort of thing. So then that was osteoarthritis. So now we're going to talk about rheumatoid arthritis. So rheumatoid arthritis is an autoimmune disorder. And basically, you guys need to know the differences between OA and RA because I know we had several questions on this, and I'm pretty sure we had a select all that apply for one of the processes. And so you had to be able to like pick out what was OA or like what was RA. So rheumatoid arthritis, like I said, is it's a chronic systemic autoimmune dysfunction that causes inflammation of tissue within a synovial joint. So this is not really known why we get it, but it's probably genetic, and it frequently starts between ages 20 and 30 and peaks around 40 and 60. So this is a little bit different than OA because with OA, remember we talked about how the age onset is usually like much older patients, whereas with rheumatoid arthritis, it tends to be in like 20s and 30s. Usually this will present with another autoimmune disorder, so like lupus, and it may develop suddenly, but usually develops over a couple weeks or months. It can affect any joint, but it's primarily the small joints on both sides of the body. So that's one difference is rheumatoid arthritis is bilateral, whereas OA is unilateral. Diagnostic-wise, we're going to do a physical exam to look for swan neck deformities of the fingers, labs, so like you might have that increased ESR rate. So remember that the more inflammation you have, the higher that ESR rate is going to be. Increased C-reactive protein is also possible, and also a positive serum Rh factor. We're going to look at autoantibodies, which is rheumatoid factor and globulins. So when you have RA, you have rheumatoid factor, and that combines with IgG to form complexes, and these then deposit in the joint cavity. And so that's what causes the inflammation. And so basically they have this abnormal IgG in their body, and so then your immune system is like, what the heck's going on? And so you produce antibodies that then attack that site even more. Usually early on, this is not seen on an x-ray, but like moderate is when you start to see like the destruction and the nodules. Severe is when the deformities are, and terminal is when there's like ankylosis. Clinical manifestations, so these are like opposite a lot of times of OA. So like with this, you're going to have prolonged morning stiffness, redness, swelling, and warmth. There's a couple different deformities of the fingers you can have. So you can have ulnar drift, boutonniere deformity, and swan neck. I'm pretty sure swan neck is like this. I think boutonniere is like this. And then ulnar is when they're like basically like pointed sideways. You're also going to have systemic symptoms. So this is one of the reasons why this is different from OA, because with OA, you don't have systemic symptoms. But since this is autoimmune, you're going to have them. So like with the eyes, you might be dry, painful, and sensitive to light. The mouth will probably be dry with gum irritation. Skin is going to have those rheumatoid nodules that like deposit in the skin. Lungs, you're going to have inflammation and scarring associated with shortness of breath. You might have inflammation of blood vessels, and you might also have anemia. So complications of RA would be like deformities, stress fractures, hematologic issues, like I said, like anemia, cardiac problems like myocarditis or pericarditis, and pulmonary problems like fibrosis and pleural disease. As far as treatment goes, we want to stop inflammation and put them in remission as soon as we can with early aggressive treatment, and we want to keep a tight control. Because these patients are going to be at a risk for infection, since we essentially have to suppress their immune system to help relieve these symptoms and prevent joint and organ damage. And so overall, that will help to improve their physical function and well-being. So the drugs that we're going to use are DMARDs, which are disease-modifying anti-rheumatic drugs. Very important. You need to know these. First one is methotrexate, which is also known as Plaquenil. One thing that you would teach your patients about these is that it can cause minor hair loss, mouth sores, and they can also target the bone marrow and the liver, so you want to watch their CBC for decreased values along with increased liver enzymes. The next one I have is sulfasalazine. So you would want to monitor your patients for a sulfa allergy and obviously not give this to them if they have that. GI and the bone marrow tends to be attacked here, so you want to monitor for your signs and symptoms of GI bleed, so like bloody stools or like tarry stools, along with the decreased CBC counts. Next, we have hydroxychloroquine, so these can cause visual disturbances, and then the next one I have is guys, I'm going to be a terrible nurse when it comes to meds. Leflunomide, which is Arva. So this is another one you want to not give if they have a sulfa allergy. And the GI and bone marrow is also attacked. Other drugs we can use are steroids for symptom control during flare-ups. We can give TNF inhibitors, so we want to ensure, and I have this highlighted with TNF inhibitors, that they don't have TB. You don't want to give live vaccines if they're taking this, and you want to monitor for infection because these are biological response modifiers. So your side effects would be like cancer, infection, injection site reaction, that sort of thing. So an example of this drug would be Humira. Another one would be Remicade. Non-pharmacologically, we're going to teach these patients with RA to eat well, balance their activity with rest, use heat and cold, relaxation techniques, topical treatments, that sort of thing. Okay, so I'm going to go through really quickly the differences between OA and RA. So remember that they're not a normal part of the aging process. OA is going to be asymmetrical pain, so on one side usually, whereas RA is going to be symmetrical and bilateral. So then with RA, one thing that's important to know is that the distal interphalangeal joints are spared and not affected. So that is your Herberdens nodes. So know that with osteoarthritis, your distal and your proximal nodes can be affected. So distal is Herberdens and proximal is Bouchard's, whereas with RA, the distal is not affected. Only the proximal is affected. So that would be your Bouchard's. One thing with OA is it's best in the morning, whereas RA, it's worse in the morning. So with your RA patients, you generally are not going to do like PT and OT in the morning, whereas OA patients, you might schedule that in the morning because as they use the joint, it's going to get worse. Whereas with RA, once they get up and get moving, it gets better. Usually you're going to feel coolness around the joint with OA, whereas with RA, you're going to feel like warmth and edema. It's going to look pinkish. You might hear crepitus and have like an enlargement of the joint with OA, whereas with RA is when you have those deformities. So the swan neck, boutonniere, and the ulnar drift, basically like twisting of the joint. Onset is slow with OA, takes lots of years, and the severity worsens over time. And RA is kind of random with the timing, and you'll have random flare-ups, but it might go up and it might go down. In terms of severity. OA, you're not going to have any systemic signs because it's not a systemic disease, whereas RA, you are. So that means it affects the whole body, and you can have fever, malaise, lung problems, heart problems, all of that fun stuff. And then, like I said, with OA, if you use the joint, the pain is going to get worse, whereas with RA, it usually gets better. Commonalities, obviously, between the two would be pain, stiffness, weakness, and also patients with either of these disease processes are at risk for depression because it greatly impacts their quality of life. Okay, so that is everything I have on OA and RA. I would definitely make sure you understand the differences between the two. So pretty much everything that I just went through, you should know like the back of your hand. The last disease process I'm going to talk about here is osteoporosis. So osteoporosis is a metabolic disease in which there's low bone mass, deterioration of bone tissue, and that leads to the bone being more fragile. It's pretty silent, and so there's not going to be a lot of symptoms that you're having this bone loss, which is why it's pretty serious. Usually it impacts women, but you can have it if you're a man too. And then also if you take like heparin, steroids, antacids, or if you have a hyperactive thyroid, you're at an increased risk. Other risk factors, if you're over 65, women are more at risk because we have less calcium, smaller frames, and bone reabsorption occurs earlier and increases with menopause. If you don't exercise enough, or if you exercise too much, and then if you have a calcium or a vitamin D deficiency, if you're pregnant or breastfeeding, because that depletes the bone, and then also living longer. But what you should know is the acronym ACCESS. So this is like pretty much the main risk factors for osteoporosis. So it's going to be alcohol use, corticosteroid use, calcium's low, estrogen's low, smoking, and then sedentary lifestyle. So know that. Other things that put you at an increased risk would be drugs interfering with metabolism, bone metabolism. So like I said, steroids, heparin, excessive thyroid hormones, antacids, that sort of thing. As far as assessment goes, we are going to inspect the vertebral column and look for Dowacker's hump and kyphosis. These patients are probably going to have back pain, compression fractures. Usually they have good x-rays, and they're not going to have bad ones unless 25 to 40% of calcium is lost. And how we detect this is the DEXA bone mineral density scan. And so the first bone scan is recommended before 65 as a baseline, and then every 15 years if it's okay. So I would know that. As far as nursing interventions go, so there's a couple things nutrition-wise. We want to obviously make sure they're getting enough calcium and vitamin D. So we're going to encourage them to eat like dairy, seafood, almonds. I would know foods that have calcium in them. We want them to have moderate exercise, not too much, not too little, and educate the family and patient on what's going on and assess their needs. As far as the drugs go, we use bisphosphonates, and so basically what these drugs do is they inhibit bone reabsorption and help to increase bone mass. And so these drugs are going to end in ATE, so ATE. So one would be Fosamax, which is alendronate. And so this one we use once a week. Oh wait, just kidding. It used to be once a week, but now we take it in daily doses. Whereas Boniva, which is ibandronate, and Actonel, which is risdronate, those are taken once a month. And so you would obviously want to educate your patients on that because they're not going to take it every day. things that are very important with bisphosphonates that you need to know and you are going to be tested on is that you take these medications at least 30 minutes before any other medications or eating first thing in the morning. You should take it with a full glass of water or on an empty stomach. And so then these patients need to remain upright for 30 minutes. And so that can be hard. And so you might give them like hand weights, you might help them walk around, because we don't want them to eat or take any other medications or lay down until after that 30 minutes is up. So remember, they take it first thing in the morning, at least 30 minutes before any other medications or before eating. They can take it on an empty stomach or with a glass of water, and then they have to remain upright for 30 minutes. Know that. And then remember, Boniva and Actonel are taken once a month, whereas Fosamax or Alendronate is daily. So you would want to make sure that your patient knows, like, are they taking it every day or are they taking it once a month? I think there's even drugs that they have for osteoporosis that are once a week, but I could be wrong. We can also do hormone replacement if they need it, or yeah. So I would know your access term for your risk factors. I would know that osteoporosis, you can have that Dowger's hump, and that kyphosis, which is where like there's that hump. Hold on, let me look and see. Section of the spine does. Okay, yeah. So kyphosis is usually the thoracic spine. That was what I was looking up. So it's like the thoracic spine, you're gonna have like a hump. Okay, so that is everything that I have for musculoskeletal. And just like that, we are done. Really quickly, I just wanted to say about critical care. I'm not going to make a video on it because there's not enough information. Thinking back on it, really what you guys need to know for critical care is the different levels of triage, because you will definitely have a question on that. So know like how to properly assess and triage. So know like if you have a patient that isn't breathing or like is too complex, then you're going to give them a black tag. If they're up and walking around with minor injuries, that would be a green tag. Yellow tag is like more moderate, and red tag is like your severe. That's what you're going to see first. So registered nurse RN has a really, really good video, or not, I guess she does have a video, but a really good page on her website that goes through them all. So I would do that because those are like easy questions. The other thing is ventilator associated pneumonia, which I'm pretty sure I had a thing on my phone about that. Let me see. Yeah, okay, so the thing I have with ventilator-associated pneumonia is you want to make sure that you elevate the head of the bed. That's like super, super important, and that you're also performing oral care because these patients are on a vent. What is that? I don't even know what that stands for. Oh, PEEP. So PEEP is positive end expiratory pressure, and that's the amount of pressure that remains in the airways at the end of the respiratory cycle. So that helps to keep the alveoli open, so oxygen can like exchange in the lungs. That's when you're on a vent. And then if you have fluid accumulation and non-compliant alveoli in the lungs, you can end up in ARDS. So literally that is all of the notes that I have on critical care, and ARDS is acute respiratory distress syndrome. I feel like we also had a question on like select all that apply and like the different, I don't know what your guys' topics were. I'm assuming they were the same, but I believe we also had a question about like the different like when you would call a rapid response. So I would know that as well. So like any sign of deterioration is when you're gonna do that. I don't know. If you guys have critical care questions, you can reach out to me, but like I don't have notes on critical care because I didn't take them. So, like I said, my group was the triage group, so like I knew triage very, very well. Yeah, I don't have notes on it. So I would know triage, I would know like ventilator associated pneumonia, you want to keep the head of the bed elevated, and keep performing good oral care. But really, other than that, I don't remember there. Like I said, and know when to call call a rapid response. But I feel like it was pretty obvious. Just know that with rapid response, like you're not gonna call a rapid response if your patient is like their heart isn't beating. Like if their heart isn't beating, that would obviously be a code blue. I think we had a question about that, so like knowing the difference between the two. But anyway, I've rambled enough. I will get this up probably quickly because I came over to my parents to use their really good Wi-Fi as opposed to the house that I'm house sitting. So, like I said, if you guys have any questions, let me know. It has been a pleasure helping you guys out this term, and I hope that I've helped you guys in at least a little bit. Or at least a little bit. Sorry, I have like no grammar today. But as always, if you guys have any questions, please let me know. I will say though, I work Monday and then I'm actually, so like I said, I'm in St. Louis right now, and then I'm driving back home to my apartment after my shift on Monday. So I will probably not be available to answer questions a lot of Monday. You can still text me or email me and I will get back to you as soon as I can, but just know that I won't be like around my phone very much. So anyway, alrighty, well, happy studying. You guys are going to do great, and let me know if you have any questions.